And colorectal cancer is something we can talk a whole year about. So, I mean, please feel free to interrupt me, and we just go with the talk as far as we see it's going. But again, I'm certainly open for questions in between. So let me see whether I can transport this here. Just quickly, a few disclosures. I have some interaction with industry. I'm a speaker for the company that produces the robots. And when I have nothing else to do, I write books about colorectal surgery. Those are my disclosures. Rachel introduced me, so I don't need to go into detail anymore. I was 20 years at USC, was temporarily the interim chairman there. And I'm very happy that I moved to City of Hope, where I'm now the division chief of colorectal surgery. So when we talk about colon cancer, or colorectal cancer, I should say, then we really need to start with the basics and sort of identify what is actually the organ that we talk about. So this is an outline of the colon, and you see different segments. I'll point them out. If you see my mouse, then here, this is the ascending colon. This is the transverse colon. This is the descending colon. Then it makes sort of an extra loop here. That's the sigmoid colon.
I'm sorry, I'm not seeing any screen share.
Yeah, we're not seeing the screen share. I wasn't sure if it was just me, but let's try again.
That's a basic thing. Let me see. All right. You should have stopped me much sooner. Let me see. This one, is that good?
No.
Oh, it looks like we're getting there. There we go.
Okay, you see my pointer here?
We do.
Yeah.
Okay, I'm sorry for that.
That's okay.
Before I just showed my face, and you already see that now, so we don't need to go back. Anyway, this is the ascending colon. This is the transverse colon. This is the descending colon. That's then on the left side. So it's like if we look at a person, then comes a little bit an extra. That's the sigmoid colon, and here's the rectum. The red stuff is the blood supply, and that's really important because the blood supply obviously is necessary for the colon to survive, but it's also indicating for us where the lymph nodes for a particular segment go. They follow typically the blood vessels. So when we need to take out a tumor, then we also want to remove the respective lymph nodes. So on the next slide, we see what a tumor looks like. And you see here, this is sort of the lining as it looks normal. And then all of a sudden you see something here. That's a picture from a colonoscopy. And you see that this looks more angry. It looks more fleshy. Doesn't have this nice, quiet appearance. That's a cancer. And it's really, what is a cancer? Cancer is an abnormal growth of cells. So theoretically, the cells in our body should have a program that tells them grow when there is a need for it. So for example, if you're cutting yourself, then there needs to be a growth of cells to close that cut, but then it should stop. And so a cancer doesn't have that stop anymore. It just keeps continuously to grow, and it can grow roots into the tissue. It can spread to other organs as it accesses blood vessels, etc. So colon cancer is a frequent thing. It is, based on the 2020 graphics, it's the third most common cancer. And that's true for both genders. So in males, it's prostate, lung, and then colon cancer. In females, it's breast, then lung, and then colon cancer. And when you sort of look at how likely is it in a lifetime that an average person gets a cancer, then it is 1 in 25 in males and 1 in 25 in females, which means that really in a agglomeration like Los Angeles County with 13 million people, we would expect that per year we have about 6,000 new cases of colorectal cancer. And those in 2020 lead to roughly 53,000 deaths. So when we look at the overall survival, and 5-year survival is typically a parameter that we think if you make it through 5 years, then there is a good chance that the cancer has actually been cured. So if a tumor has been a localized tumor, that it only is within the bowel itself, then the chances are really good. I mean, over 90% chance of success. If there are lymph nodes involved, then it goes down a little bit. But if the tumor has started to spread to other organs, then it becomes a bit more of a challenge to cure such a patient. It's not impossible, but it certainly is a bigger challenge. So when we talk about colorectal cancer, the biggest fear that patients have is colon cancer, I get a permanent colostomy. And that is a fear that unfortunately is not only coming from the patients, but a lot of the non-colorectal providers express the same fear. The reality is it's not true. And we get to that in a little bit. If we look at the trends of colorectal cancer, then we see a nice decrease for most. So here you see the since 1975 essentially, or 1960, so 85, there has been a steady decrease in the number of cases, both in females and in males. The mortality has also decreased a little bit, except in young folks. So we see an increasing number of young folks, and every so often we see a prominent person like Chadwick Boseman, who passed away from metastatic colorectal cancer. By the way, he still shot a lot of movies while he had the cancer, and he didn't share his suffering or his illness with many of his co-workers. So amazing how he was able to still perform very well. This is again an illustration, and I don't know whether you see the yellow curve. The yellow curve is the colon and rectum. That's the trend in females. And here in males, it's going slowly down. So sure enough, there have been a lot of changes in the last 40 years. And one of the changes that we have noticed is obviously chemotherapy has changed dramatically. And chemotherapy has, even in light of metastatic disease, allowed to get patients survive for many, many years. Sometimes we have patients who have metastatic cancer and they don't ever get it out of their body totally, but they keep it totally suppressed and they live 10 or more years with some tumor. Even though it's not going away, they can survive and remain relatively asymptomatic. And that is by the introduction of very, very sophisticated, and initially in the 1960s, I mean, there was barely anything. And then came the first chemotherapy agents. And nowadays it's a really highly sophisticated world, very complex to think about how can a tumor be attacked with pharmacological tools, etc. So who gets colorectal cancer? Well, I mean, if you just go by the folks who you might recognize by name, Ronald Reagan had colon cancer, and those are all public, this is all public information, so I'm not sharing any protected health information. The Queen Elizabeth, the Queen Mother, that should actually be one line, she had colon cancer. Corazon Aquino did, some baseball players did, actors did, Katie Couric's husband did. So a lot of folks did. And so the bottom line is, it's everyone. It's mothers, fathers, sisters, brothers, you, me, and so forth. So everybody is at risk. There is no discrimination. It can affect everyone. The good news about colorectal cancer is it is preventable, it is treatable, and we can beat it if we encounter it. Facts about colorectal cancer are the colon can be visualized in its entirety. We can do a colonoscopy and see essentially the entire colon internally. The evolution of a cancer it doesn't happen overnight. It is a slow process. So from a totally normal looking colon through the precursors of a polyp until it's truly a cancer, that's a relatively slow process, and that can take up to 10 years. In some people, some with specific genetic risks, that sequence can be compressed to less years, but an average colorectal cancer is 10 years. The bad news is, again, we're all at risk, and we may not know about it, at least until you have some symptoms. So we need to look out for symptoms such as rectal bleeding, bowel urgency, frequency, etc. So how do we prevent colorectal cancer? First of all, we need to know the enemy. We need to understand how it evolves. We need to understand what causes it. We need to understand how to detect it, and we need to understand how to treat it. So when we look at the whole population as such, then we can group everyone into one of the three categories. There may be the low risk. That's just average folks. They have no specific risk factors. They have no cancer in their family. So still they have a risk to develop a cancer on their own. Moderate risk are folks who have some additional risk factors. It could be, for example, that they're younger, or that they had, that they have a first-degree relative who had a cancer at a younger age, or that they have several family members with colorectal cancer, or that themselves they had a history of cancer or a large polyp, etc. So I'm not saying that this is the entire list, but these could be things that should sort of raise our attention and make us think, could there be something else? And then there are sort of high-risk constellations, and those are patients who we know they have a risk, such as some genetic syndromes. We give it a name, it's called FAP, or it's HNPCC, and you don't need to know those things, but essentially those are situations where the body has a mutation that is present in every single cell, and in the colon, that mutation can trigger the growth of a cancer. IBD stands for folks, for a disease called inflammatory bowel disease. And those are patients who have an inflammation of their colon or their intestines for many, many years. And if that inflammation makes that colon so angry, after a while it can trigger the growth of a cancer. And usually that's not a thing that happens after a year or so of the disease, but after 10, 15 years or so, we see that there is an increased risk. And that's why we need to obviously keep an eye on those folks. So I talked about these intrinsic risks, but there are also extrinsic risks, which have more to do with lifestyle, sedentary lifestyle. Obviously the diet, what we put in, somehow will affect what's happening in the colon. And we certainly see that societies where we consume a lot more red meat and less fiber, etc., those have a higher chance to get a colorectal cancer. There are other things like smoking, alcohol, certain vitamin deficiencies. So for example, lack of vitamin D and so forth. They don't trigger the cancer in 100% of the folks who have not enough vitamin D, but overall, it makes it easier for cancers to start growing. If somebody had a previous history of radiation, so for example, if a woman has had uterine cancer and gets radiation for that, then we need to keep an extra eye on that rectum just to make sure that the radiation does not promote any risk. Here I took a video from the American Cancer Society, and I just want to play it real quick because I think it sort of illustrates very well what we're talking about, and I hope we can hear this.
My family means the world to me. Probably the reason that I've survived everything that I have. If it was just me, I may not have made it this far. Every challenge that I come up against, I have their love behind me, pushing me forward. There's nothing that I have encountered yet that has been able to stop me with them by my side. My name is Rick Rivers, and I've been diagnosed with both colon cancer and with kidney cancer. I've had a family history of colon cancer going back at least 2 or 3 generations. I did not hear about cancer when I was young, not in my home. The big focus was on diabetes, but not so much cancer. I really didn't have any conversations about cancer. A lot of men are not diagnosed as early, and that is due to not having proper screening. Maybe a lot of people are believing that if I don't test, maybe I won't have it, but that's just, the ignorance of bliss. And so a lot of men, especially Black men with a family history of colon cancer, should get scanned very early on. I think one of the big hurdles with getting screened for colon cancer, the biggest one is fear. It's the biggest one. Nobody wants to hear that. And if you don't ask, then you don't get the answer. But you have to get past the fear factor. So it's one thing to be scared to hear something. It's another to die from not hearing something at all. I think one of the big hurdles of the conversation not being had regarding screening, especially colon cancer, is that it's kind of taboo. I mean, it's kind of hard to talk about anything in that private realm, and people usually shy away from it. If you're somebody who has a platform in your community that can address men in your community, then it is your responsibility to let them know that this is something that they should be doing. And once they hear the conversations, once they hear that it's okay, once it becomes normalized, it's not a taboo subject anymore, and then we can have it without problem.
There are more of those on the website of the American Society of Colon and Rectal Cancer, on the website of the American Cancer Society. So he talked a little bit about a family risk. And so how does cancer develop? Typically, there is a need for some mutations to happen. So there is a program that tells the body how to work normal. And in some folks, that program has error messages. And if you have a constant turnover of cells, they need to obviously get replaced, etc., then there is a space for errors in replication. If you think about, take a text from a book and just copy it, type it on your computer, type exactly what's written on that page. I'm very sure that you will, at least I will make a lot of mistakes. And it's amazing how precisely the cell in the body can copy such a page with very, very few errors. And if there are errors, then they can still correct them. But occasionally an error slips through. And occasionally such an error means that a cell has a better chance to survive and to continue growing. And that's how over time a cancer starts to form. There is not sufficient cell death, so the cell doesn't know anymore when it's time to shed off, etc. And there are too many cells that actually form, and that's how something like a cancer can grow. Here I have a graphic illustration from essentially a normal colon through the precursor of a polyp, then a slightly bigger polyp. And you see in this area of the polyp, there is all of a sudden a darker spot. That's a cancer that starts to form. So far, this cancer is far away from the bottom, from the base of the tree. But if the polyp gets bigger, then it starts to grow into the wall. And you see here in a colonoscopy, a picture. Once it's in the wall, then it can find access to blood vessels and lymph vessels, and it can spread to other organs. There are X number, and trust me, I don't know all those genes myself either. That's a highly specialized topic where geneticists, etc., and scientists know all those genes. But the bottom line is we need to intervene before it gets to that if we can. And the good news is we have a good opportunity to do so. So almost all cancers start in a polyp. We all have a high chance to get a polyp by 50 years of age. 30% of the people have polyps by the age of 80, 55. And again, since it's so slow, if we chop away those polyps before they grow into the cancer, we have a good chance to reduce the cancer risk by 85 to 90%. This is how the tumor then grows. So we have, again, a tiny little growth here. It's already a cancer. So it's growing already into the depth of the bowel wall, but it has not penetrated to the other side, and it has fortunately not gone to the lymph nodes. Here, it's getting a little bit deeper. So it's going through the wall to the other side, and in the process of doing so, at some point it will access lymph vessels, and it can affect those lymph nodes, which are sort of the first filter station of the colon. Once it sort of leaves the confinement of the bowel, then all of a sudden it can start to spread into other organs. And that's what we call metastases. So here are what the chances of survival were in 2004. And you see, again, if you have different stages, 1, 2, 3, 4, and overall with a stage 1, the chances are very good. With a stage 4, it's not impossible to survive, but it's certainly much less likely. So again, if we can intervene before it's getting to that point, we have obviously a great chance to deal with things. It is important that symptoms alone are not sufficient to diagnose a cancer. So the most frequent symptom of a cancer is that it has no symptoms. When we start to have bleeding, low blood levels, change in bowel function, for example, constipation, or changed diameter of the stool, or a complete obstruction, etc., abdominal pain, or you even feel a mass or so, those are typically late symptoms. So we should always look for stuff before it happens. And again, I have a lady who wants to tell her story.
So when the surgeon came out, she, looked really concerned, and she told us all to, gather around, and she was going to tell us how the surgery went, what was going on with my mom. And the last thing you want to hear is that your mother or your father or anyone in your family has cancer. She was diagnosed on September 2nd, and by December 8th, she had passed away.
Sorry, for some reason, there is a little hiccup here.
When my mom was alive, she knew that
Welcome to a nice internet connection.
Strange issues with my bowel.
She would make some comments through the years, even in advance of her mom getting sick.
Thin pencil-like stools and a lot of indigestion, a lot of gas.
And I know she had some minor concerns, but I don't think either of us realized or thought anything was really wrong.
A couple times when I would run and I'd come home, I felt like I had to go to the bathroom. When I did, it would just come out all blood. I thought, hemorrhoids. 37 years old. There can't be anything more than just hemorrhoids.
After her mom's passing, it became imperative for all the siblings to go and get checked.
I didn't so much fear having the colonoscopy because I heard that it's nothing. It's, you know, I didn't want to find out if I had cancer. I mean, that was frightening, really frightening. I mean, I had symptoms for 2 years and I just knew that something was not right. I never thought cancer.
The doctor finally came in and sat down and, you know, definitely had a look of concern on his face. And he told us at that time that she had an extremely large polyp. It was too large at this time to be removed, you know, by him. He would have to do a surgical process. He did some exterior biopsies on and was going to send that out to be checked. They anticipated it was going to be about a week till they got results back. That was a long week, not only for Allie, but for me as well.
They came back non-cancerous, that it was a benign polyp. One of the options is to have a TEM procedure done, which the polyp is removed anally. You know, they go up and pull it out. So my sister works with a surgeon in Minnesota, and he's one of only a few doctors throughout the country who performs this procedure. We were sitting in his office with him. He was looking, you know, through the paperwork and the results of the biopsies, and because of the size, because of how it looked, you know, he looked at me, he looked at my husband, and he said, I can guarantee you that there's cancer in this. And then you go just kind of blank. He explained what the standard protocol is for rectal and colon cancer. It's chemotherapy first with radiation to try to shrink the polyp, and once that's done, you go in for surgery. You have the rectum taken out, you wear a temporary ostomy bag, you have everything resected, and then you just continue on from there.
It was that first day that she went in for her first treatment, and she sits down and the nurse comes up. She has the pump, she has a needle injected into her, and when she first puts the needle into her port, I looked over at Alice and had tears rolling down her eyes, and that was we knew it was real.
I just knew that these were the steps I needed to take if I wanted to get well. I had no choice.
I think when the first day comes, you have this battle in front of you. I don't think you have any idea of how much goes into it, how much you have to do as a couple. And you know, the good news is the worst part is behind us right now. The major treatments, the surgeries are behind us. So you know, now we're in a preventative stage, and you know, things will get easier from there.
The only thing.
So again, what this lady has also illustrated to us is that we need to try to get it early. We need to get it hopefully before we get the cancer. And so the goal is that we reduce the overall incidence, the times such a cancer develops. And that could be by us reducing extra risks, adapting to a healthy lifestyle, maybe making changes to the diet, add supplements, medications, etc. And sure enough, look and get those polyps out as much as we can. So detecting the cancer early or detecting the cancer before the cancer occurs is really absolutely crucial. And I'm again repeating that specifically this month because March is Colorectal Awareness Month, and we should get the word out that everybody who hasn't gone and done a colonoscopy, who should have a colonoscopy, should get it. So we do the prevention, we do the treatment, and once we treated someone with cancer, we obviously got to make sure that we keep looking and making sure that not a new cancer forms or that not a cancer recurrence develops, because the earlier we catch it, the better we have a chance to, again, intervene. So colon cancer screening 45 is the new 50. So until about, I forget, probably about 4 years ago, it was recommended that everybody starts screening once they turn 50. Screening means you do a colonoscopy if you have no symptoms. So you're perfectly healthy, then you should get a screening. And again, now it's not 50, but it's 45. If before 45 someone has significant symptoms, change in bowel habits, bleeding, hemorrhoids, anything like that, we should start looking before the 45. And that's something when you know somebody or yourself, you have some symptoms or so, and the doctor says, well, you're not 50 yet, then you need to say, well, but I think I should be checked. So again, if we can remove those things, we can prevent it from turning to cancer. And here you see a polyp. It's sitting on a little trunk, like a little tree, a little stalk. This here, I don't know whether you see it well, is a wire sling. We place it around the polyp. We can administer heat and energy, and then the polyp falls off without causing any bleeding. And here you see the base of that polyp, and that is history. So that specific polyp cannot turn to a cancer anymore. So when we sort of ask ourselves, what tests do we have for colon cancer screening, then we have stool-based tests. And those are any kind of test where a piece of stool is examined, and there are different tests like an FIT test, or what's gone through the news or so is typically a Cologuard test, or that's more the best tool is obviously a colonoscopy. There are alternatives to the colonoscopy as well. Can I do some quick change in my presentation here and ask you so far whether you have any questions? I need to quickly, there's something, an error happening here, but if you quickly put unmute, and then if you have any questions so far. Rachel, you want to take a lead?
Yeah. Well, people are welcome to unmute themselves. I am getting a couple questions in the chat. Just one question around, could surgery improve survival outcomes for stage 4 cancer?
Absolutely. So I think what we see very often is that people are told by either their family or by the physician who they see first, or even some specialists, hey, you have stage 4, book a trip, that's it, you're done. And that's not the way how we look at things. We really think that there is very often a good chance that we can do something good for somebody, and that we can maybe change the sequence of how we treat a cancer. And if my corrected presentation loads correctly, then it should come up. I just saw that there were some errors in the presentation. Give me 2 seconds.
No problem.
Any other questions right now?
Yeah, I'm going to summarize this one a little bit, but I was diagnosed with rectal cancer a year ago, had surgery, then a scan revealed it had gone to liver, lungs, and one small lesion in vertebrae. Started chemo, was switched to maintenance chemo. When I asked my doctor about a prognosis, a couple of years. My October and February scan showed all lesions have continued to reduce in size. Are there any research around options to prolong my life?
So obviously it's a little bit difficult to go into someone's individual history without having the specific details, but the general philosophy is that you should have the area assessed and somebody make some statements about it who doesn't write you off from the beginning. So we see patients throughout the country here at City of Hope and even some renowned places like Mayo Clinic or MD Anderson or so sometimes says, no, we don't offer you anything, and yet we can operate on them and get them cancer-free. That's not obviously a guarantee, but I think it's an opportunity. And I think it's really important that somebody who is willing to go an extra mile looks at such an individual's situation and defines, this is what we can do, and this is what is unfortunately unrealistic. So let me just quickly restart my presentation here. I'm sorry for this interruption.
Dr. Kaiser, we have a question. Someone's asking if you'll be sharing slides.
I can create a PDF and share that. Okay, so I think I'm back on track. I'm sorry, I apologize for that little hiccup that I had. So the again, I essentially stated that we need to do the prevention and so forth. And what we really try to achieve is a way to cure the colon cancer. We need to involve basic science. We need to involve epidemiology. We need to involve the screening, diagnostics. I think you see where this is going, right? We need to do precision surgery. We need to do precision medicine, and we need to have precision radiation. And with that, we have maybe a chance to cure this cancer. This slide, again, was a little bit out of order, and that's why I realized. So here again are the tests that we can do for the stool, and here we have the tests that we can do for the colonoscopy. And I'd like to point out here, this upper area, that's a normal colon. So we see it looks smooth. You don't need to be an expert to see this looks sort of very regular and smooth. Whereas here in the lower part, there is something angry, and that's a growth, that's a cancer. So the colonoscopy, if you look at when these things are needed, will have to be repeated. These stool tests typically have to be done at least every 1 to 3 years. Whereas a colonoscopy, if it's negative, you can wait up to 10 years. So, and that is because you can really visualize directly. And you can not only visualize, but you can also take biopsies, you can remove the polyps. And so for that reason, it is the gold standard. Alternatives are a virtual colonography. And this is a virtual colonography. And you see sort of a CT scan that is done with some air blown into the colon, and the CT scan then reconstructs it. For that procedure of a virtual colonoscopy, you also need to do a full bowel cleansing. In fact, you need to probably do it better because any tiny little bit of stool could be misinterpreted as a polyp that's sort of sitting on the wall. And so this is what it looks like when you fly through. You get a fly through here, and you drive virtually through this colon. There's no instrument that touches this. It's just the computer that reconstructs this area based on what the images see. So that's a virtual colonoscopy. Again, it needs a full bowel prep, and it can't necessarily distinguish between 12 things. But you see on this slide, on this little inset here, that's a polyp. And if you saw that on a virtual colonoscopy, then you would have to schedule a true colonoscopy and get rid of this polyp. So what do we do once a cancer has been confirmed? So first of all, we need to do pathology. We need to look at it under the microscope, but then we also need to do specific tests to look at the genetic profile of such a tumor. we need to do additional tests. We need to do a CT scan. Sometimes we need to do an MRI. Almost never in the first management do we have to do a PET scan. We need to look at somebody's overall health. So we need to check heart, lung, liver, kidneys, and so forth, brain, just to sort of have an understanding, is it reasonable for such a person to undergo a surgery or a strong chemotherapy or whatever? We need to know what are we actually dealing with. And once we have achieved that, then we do some decision making. So the choice of optimal treatment depends on a number of things. First of all, it depends on where is this tumor located? Is it in the colon or is it in the rectum? Are there complications of the disease? So has the tumor, for example, led to a complete bowel obstruction? Has it ruptured? So that translates into the question, are we talking about a planned surgery or are we talking about an emergency surgery? And you can imagine that if somebody comes with a ruptured bowel, that is a more challenging situation than if you can set it up nicely, you book it, the patient can clean out the colon, get rid of the stool in preparation. So obviously different circumstances. Then there are patients who have a colon cancer that develops on top of an underlying disease. It could be a genetic disease or condition, or it could be inflammatory bowel disease where the whole colon may have the same risks. And we need to really talk about not just removing that one segment, but maybe the whole colon as such. And apart from looking at the overall health of the person, we really need to make a distinction whether we talk about a rectal cancer or a colon cancer. And with that, we then have essentially the three specialists, the surgeon, the oncologist, and the radiation oncologist sit together and decide with the family how we can define the best outcome. So I mentioned that we need to distinguish between colon cancer versus rectal cancer. And for the distinction is about here. So this is the rectum and this is the colon. And why is it relevant? Because the colon typically follows the blood supply and the lymph nodes all along those vessels, whereas the rectum has a much earlier chance to spread the tumor sidewise and go to the liver and lung and so forth. And it has a higher, it's sitting in the pelvis next to other structures, the bladder or the uterus or the prostate and so forth. And the area is just a more densely populated, so to speak, area where the organs could interfere with each other. And that's why we treat the rectal cancer typically slightly differently than the colon cancer. So if we have a colon cancer, we typically, unless there is so in a patient who does not have signs of spread of the tumor to the liver or the lung or so, in those we first do the surgery. So we remove the cancer, then the pathologist will look at all the nodes and so forth and give us a definitive stage. Before that, we don't have a definitive stage, we can sort of speculate. Depending on that stage, we then add chemotherapy afterwards. In the rectum, again, this is this portion here, it's a little bit different. Here, we considered starting with chemotherapy and radiation therapy unless it's an extremely early stage. And we wait with the surgery for later. So we first pre-treat the cancer, hopefully it shrinks, sometimes it disappears 100%. And then we have a different question, should we in fact still operate or should we just what we call watch and wait if that cancer has totally disappeared? If we have a metastatic cancer, so not the slide from before, but this time the tumor has already gone into other organs, the liver or the lung or somewhere else. And in those individuals, we typically start with the chemotherapy, except if there is a complication of the tumor. So for example, if the tumor obstructs, if the tumor perforates, ruptures, or causes massive bleeding, maybe we need to do surgery to mitigate that complication and then do it like in the previous case, start chemo and radiation or so afterwards. But if we have none of those, then we would typically start with the chemo because the chemo goes into entire body and can even go to the sites that are not where the tumor started. Surgery for colorectal cancer, it's not a car repair. It's not just opening to a few things. It's really become a very specialized and sophisticated specialty of surgery. And the quality of the surgery is directly related to the survival and the cure rate of such patients. So overall, if done properly, the surgery has become very predictable, very safe. We can't promise someone that there won't be any complications. Surgery has potential for complications. However, what we should be able to promise a patient is that we do our best to avoid those complications, that we know the story of a patient, that we know the anatomy, that we do a very careful dissection, and that we have a good chance to have a good outcome. And only rarely does a colorectal cancer require a permanent colostomy. So here I have a few examples how we resect, and you see the darker spot here in the very thing, and the gray area is what we would typically take away. Now you may argue, oh, this sounds like a whole lot of tissue that we removed just for this one spot. And the truth is, we need to look where this cancer might potentially spread. So it could follow those blood vessels and even go here. So that's why we sometimes need to take on the colon a lot more, but typically we can leave behind a substantial amount of tissue such that the bowel function still looks reasonably well. Now, there are different surgery platforms. There is a conventional open surgery, and that means that we do a big incision from whatever, somewhere typically in the midline, and it's probably 10, 15 inches long, and we need to just get our hands in and deal with the cancer and the bowels and so forth, cut it out. And that's a good surgery. That's sort of the historic standard. But over the last, I would say 30 years, minimally invasive surgeries, laparoscopic surgery or robotic surgery, have shown to achieve the same thing, but with smaller incisions, leading to less pain, leading to a hopefully faster recovery, and that we can that way really deal with the cancer. And occasionally there are some situations where we can do the surgery where we don't need to cut through the belly, but we can come from below and do what we call a transanal surgery, for example, transanal microscopic surgery. The lady also quickly mentioned that in the video that we heard. Robotic surgery means that we have small incisions, we can have a 3D vision, and almost all work is done internally. We obviously need to somewhere make an opening that we can retrieve the piece of bowel. So if we deal with a very large tumor, that incision to retrieve the tumor is going to be a little bit bigger, but oftentimes all we need to do is like 4 or 5 centimeters, so less 2 inches or less, and we can remove the colon that way. Now what you see here is a patient, and you see almost no patient, right? The patient is hidden underneath and the robot stands here, and the surgeon is in fact not standing next to the patient like in a conventional surgery, but he is in a console or a cockpit where we direct the robot to do what we think needs to be done. The robot doesn't know anything. The robot is not a autopilot thing. It's really the surgeon who just takes the advantage of the robot to sort of make the movements maybe a little bit tremor or whatever. It makes it and smoothens it out that we can do a very precise dissection of the tissue. And it has some advantages, and if you find it gross to look at bowel, then please close your eyes real quick. But this is a piece of bowel, and it looks overall very, very healthy with our eyes, but we see with special technique that we can use during the robot surgery that this segment here has less blood supply, so we would obviously want to go to an area where it's really good. Only if we have a good blood supply, then we know we can do a reconnection that heals well. So here's just a few examples. This is a gentleman who required this big of a resection, huge resection, and all he has is these small incisions. Paradoxically, even though we take away the this part, the incisions are on the opposite side. And I have to tell the patients in advance, because sometimes they come, if I forget to mention that the incisions will be on the opposite side, they say, did you really take out the right segment? And yes, I sure did. Here are some other gentlemen. And again, these have removed both a lower part like the rectum, and you see very small incisions. This is where we removed the piece of bowel. So it's very small. This guy was running a marathon about 4 weeks after his surgery. I mentioned that we can sometimes remove the cancer or a larger polyp. This is a polyp. We can remove it through the anus, and it's a little bit similar. We have a video screen. We can go in with instruments and very carefully dissect this segment off and then close it, that it has a nice chance to heal. I mentioned before that for rectal cancer, we typically start with radiation first and then do the surgery and maybe do more chemo afterwards. There are newer versions where we do all treatment, radiation and chemotherapy first and then do the surgery. And sometimes in 15 to 30%, the tumor disappears 100%. So the question then is, should we still operate or should we watch and wait? And what you see here is this area was the tumor. So you wouldn't really see it, except that it's a little wider. It has maybe a little bit more blood vessels, but this was a tumor that looked the same as the ones that I showed earlier, angry, big, ulcerated, nasty looking, and it totally disappeared. So in some of those individuals, again, we offered to just watch it, and we need to keep watching frequently to make sure that it doesn't come back. So one of the big questions is always, will there be a stoma? And again, even if we do radical surgery, most commonly we can save the anus. We really need to remove the anus and create a permanent colostomy only when the sphincter muscle as such is involved with the cancer. If we go very low and if we have had a previous radiation treatment, then we know that the tissues maybe don't heal as nicely. So when you break your arm, then you typically put it in a cast to let it rest and heal. When we operate on that area very low and it has been radiated before, then we want to give that area a chance to heal, and we give a temporary ostomy. And that prevents the stool from going through that freshly operated area. It's like the Band-Aid. And once we see that everything has nicely healed, then we can do a much smaller operation and put everything back online. And a permanent colostomy is really only necessary if we have an extremely low cancer that involves the sphincter complex. Sometimes if we have everything looks fine, but it just doesn't work to a patient's satisfaction, then sometimes they come back and say, I prefer to have a stoma again because I've become more predictable. So that's the overall rare cases. And I would say in 100 cases of rectal cancer, the permanent colostomy is probably necessary in about 5% only. So the majority, we can restore continuity. So in conclusion of this quick 30,000 feet overview of colorectal cancer, these are the take-home messages. Colorectal cancer is frequent. It can affect everybody. It is preventable if we look early enough. It is very treatable, and a permanent colostomy is very rarely necessary. Temporary, yes. A permanent, very unlikely. So there is light at the end of the tunnel but there is obviously still a lot of work that we need to do, and certainly a lot of education that needs to be done. We're happy to offer you many of those services at City of Hope, but we certainly know that other institutions have also the expertise to do so. So thank you for your attention, and I'd like to open the microphone again for questions.
Well, thank you so much, Dr. Kaiser. This was so thorough and helpful, and I'm just always so amazed with the research that City of Hope is doing and has access to. Just gives a lot of hope. There were some questions that came in the chat. One is, I'm in remission from stage 3 colon cancer and I'm afraid of recurrence. Is there anything I should be doing to prep for the chance of recurrence? I'm doing recommended surveillance, CT scans every 6 months, blood work every 3 months. Is there any research or preparation I should be doing?
Having the diagnosis of a cancer obviously is also associated with a substantial degree of anxiety. That is just inevitable. You hear the C word and it's not going to leave you. Even if you're 5 years out and you have not had a cancer recurrence, somehow it's always in the back of your mind, and there is every little symptom, every scratch that you have, you wonder, is this now a cancer or so? So to some degree, we can't avoid that. And I think it's important that you do your regular follow-ups, and the regular follow-ups are really a little bit dependent on the stage. So if we have an early stage, it's not as frequent that we need to check as opposed to somebody who has a stage 3 or so. We really need to keep looking frequently enough, and it can be with just a clinical exam or with blood work. We need to do imaging every so often. We need to do colonoscopies. And we can't 100% promise you that it won't come back, but we can look again to make sure that we see it frequently enough that we see still an opportunity to go after that cancer.
Great. And then another question, do other medical teams use robotic surgery like City of Hope?
Can you repeat that question? So other teams?
Yeah, do other medical institutions use robotic surgery, perhaps in our greater community?
So the robot has become a bit more prevalent. I think overall in Southern California, we do the highest number of colorectal robotic surgery here, but most other institutions have started to buy robots. The robot is just a tool, and the robot, as I said before, doesn't know what he or she, whether it's a female or a male robot. It doesn't know what it needs to be doing. So it's dependent on the judgment and the skills of the person who actually sits in the cockpit. And so again, we're not claiming we're the only institution who can do that. As I said before, I was at USC, and there are many major centers in Southern California. But it is important that when you are faced with the diagnosis of a colorectal cancer, that you really query the person that you're dealing with. Are you doing this this way or that way? What is your experience and so forth? That you just really get a sense of getting the best care.
Great. And then another question is, someone had 2 negative colonoscopies, and she's wondering whether she needs to continue having colonoscopies, and she says she's 68 years old.
And you had a cancer before?
She didn't specify.
No? So at 45, you do the first colonoscopy. If that colonoscopy is totally normal, there is not, first of all, it was very clean. We could see it very nicely. And we see not a touch of abnormality, no polyp, no nothing. Then that's good for 10 years. If, on the other hand, we saw a bunch of polyps, then it depends a little bit what those polyps were. Were they small or big, or what type of polyp? And then it could mean that you need to have another colonoscopy as early as 5 years after the index one, or if the situation demands, it could be 1 year or 2 year or 3 year. So that's something that your endoscopist should tell you. Now, you get your second one 10 years later. And again, the same thing. If it's totally normal, then it's again good for another 10 years, unless symptoms develop earlier. So that's really the question that you need to ask the endoscopist, and it should be written in the previous report. Now, how long should you be continuing colonoscopies? Should you stop at some age? And I think that's not totally written down in our guidelines. I think it really depends a little bit how fit a person is. And if you're otherwise fit, I would encourage you to continue doing the screening. It's a little bit of a hassle to do the cleansing, etc. But on the other hand, it gives you sort of reassurance. If you think if you had a cancer, you would take care of it surgically, then it's better to prevent that cancer before it occurs. So it needs to be a little bit individualized, and it needs to be made dependent on the findings of the previous colonoscopy report.
Sure. And then another question is, why is it that symptoms don't appear until the cancer is typically later stage?
So just think of it as, again, it's a tube. The colon is a tube, and stuff needs to go through. It starts really to cause symptoms only once that growth starts to interfere what the colon is supposed to do. So it needs to pass the stool. Now, if you have a tumor on the side closer to the rectum or in the rectum itself, and the stool that arrives there is already formed, then obviously the tumor may be smaller before it starts to interfere with the passage of that formed stool. If you have the same sized tumor on the beginning of the colon, then the stool is still more liquid, and it can easily pass through until really it starts to narrow it totally down. And the same is true for bleeding. If you have just a small polyp or a small true cancer, that may not get sort of disrupted by the passage of stool, but once it's getting bigger, every single time you move the stool through there, it's mechanically irritated. It rubs on that surface of the cancer, and because there are so many blood vessels and it's sort of mechanically irritated, then it starts bleeding.
Okay, and then the last question that I see in the chat is, how do CT scans and MRIs differ in the images that they offer?
So obviously it's a totally different technique. And sometimes we need to do both. Sometimes we do one or the other. Sometimes it's truly one could be replaced by the other one, but it's not always possible to do one in every patient. So that's true for CT scans, that's true for MRIs. MRIs have the advantage that there is no radiation, but usually they take longer. And it means that the patient needs to be for a while in a relatively confined space. And it's kind of noisy to be in there. So some patients get a little bit of claustrophobia in that space, and they prefer not to have an MRI if they can avoid it. Sometimes they can't have it because they have a pacemaker or they have a hip or something like that that prevents them from doing an MRI. So there may be not a one size fits all, but both the CT and the MRI, they essentially try to image the body and just get a series of slices of images, and based on that, they try to reconstruct what we see inside. Then it depends a little bit on the disease that we're looking at or the organ. If we look at the liver, for example, oftentimes a MRI gives us a slightly better resolution of if there is a metastasis, how close is it to the blood vessels, etc. And can we resect it? Do we have to leave it, or how much of the resection do we have to do for that liver metastasis, etc. Any other question?
Sorry, I had myself muted. That is all that I see in the chat, but people are welcome to unmute themselves if you have any remaining questions.
I hope my glitch with the computer didn't interfere too much with the flow.
Oh no, that's perfectly fine. I think you know, we all have had our own fair share of tech difficulties this past year, so it was perfectly fine, and we got a little Q&A break that way. So thank you so much for your time, Dr. Kaiser, as well as sharing all of your wisdom. And also, I neglected to thank the two physician liaisons at City of Hope that helped organize this presentation, Crystal Morse and Douglas Nyland. So thank you both for your help as well. We so appreciate the collaborations with City of Hope, and thank you so much, Dr.
Thank you very
Kaiser.
much for the opportunity. It's my pleasure. And sure enough, I listed my email here. If you have any specific questions, do not hesitate to reach out.
Thank you so
All right.
much. Good
Have a
night,
great evening.
everybody.